I've told some of you in my clinical group, but my dad is having a really, really big surgery at Cleveland Clinic next week. Next Monday afternoon is on part of it, the rest of it is on Tuesday morning. So I will be here Monday for class, and I will lecture. And then I'm leaving right after that to go to Cleveland. Wednesday, your lecture will be recorded. So you will not have class Wednesday. No class next Wednesday, a week from today. The lecture will be recorded by the end of the weekend. So it'll be available by Sunday evening. You have all week. You can watch it as many times as you want. So that's the advantage. You can watch it as many times as you want. But there will be no lecture on Wednesday next week. So those of you in my clinical group, I've discussed it with you a little bit. I'll discuss it with you a little more tomorrow. I anticipate, barring nothing tragic, unforeseen, being back the next Monday for class. So no class next Wednesday. Lecture will be recorded in a real life. Okay. Okay. So, 1 week from today, yes. March the 3rd, 1 week from today. No class. 1 week from today. Let's see. Yeah, because the 28th is Monday. The first will be whatever 1 week from today is. All right. So, what's a healthcare disparity? What does that word mean? If there's a healthcare disparity between you and me, what does that mean? There's a difference. There's a difference made in how I get treated and how you get treated, right? So are there health disparities between populations in this country? And heck yes. This is the United States. Yes, we are, supposedly the top of the heap. But there are a lot of healthcare disparities in this country. What are some factors that you think would cause a healthcare disparity? What would make one person get treated better than another?
No insurance.
Insurance is huge. Income, because if you don't have income, then that ties to your insurance too. You may or may not have insurance, or if you can't pay the bill, obviously. And some places won't even treat you if you can't pay the bill. Now, a lot of hospitals like CAUC do charity care, so if you come in, they'll treat you. But a lot of doctors' offices or other places will not if you don't have the money to pay the bill. So your income and your insurance status. What else? Your lifestyle. Don't think that there are people who have lifestyles that are, more high risk than others, let's say, and cause people to be less likely. A lot of these people are less likely to seek care because of their lifestyle. If you're an IV drug user, if you have hepatitis C, if you're HIV positive, you need health care more than the general population, but a lot of times those individuals are very hesitant to seek it because they don't want to be condemned for their lifestyle. They don't want to be embarrassed about their situation. So lifestyle, good. What else? Your race, yes. As much as it pains me to say it, racism is alive and well in this country, be it African American, be it Hispanic, be it whatever the ethnicity might be. Race is going to have an impact on healthcare disparity for sure. Yeah. What else? You think women? Well, yeah. Women. Because a lot of times women are still dependent sometimes on men for their insurance. If they're married, they may not have. If they get a divorce, they don't have insurance anymore. Or they work at a job where insurance is not offered. That can happen to men as well, but it seems like it happens to women a lot. And women need a lot of health care at certain points in their lifespan, especially during their childbearing years. When you're young and healthy as a female from 20 to 30, there's a lot of care that you need if you are childbearing. Men, if you're young and healthy, between 20 to 30, not nearly so much. So the need for health care is greater, the disparity is greater. So we could probably go on, but those are probably the biggies. I would say there's a disparity between men and women, definitely races, income, lifestyle, yes. So healthcare disparities are alive and well. And the goal of, have you all heard of Healthy People 2020, the whole push to increase the access to healthcare and improve healthcare? The goal for Healthy People 2020 is to reduce healthcare disparities. And a lot of those healthcare disparities will lead to problems in mortality and morbidity. And we're going to define those words in just a minute. If you don't know what those words mean, we're going to talk about the definition. So we do see in women more birth defects, more STIs, shorter life expectancy, higher infant mortality rates within certain ethnic groups. We can look at the percentage of how many African American women have, what's the morbidity and mortality rate versus the general population. And it should be equal to however many percent are in those countries. So, for example, if in the United States, of women in the United States, if 13% of them are African American, then the mortality rate should be about 13%, right? I mean, it should be about the same. Well, it's double or triple that. So that's telling us that more African American women are dying at much higher rates related to childbirth and women-related care than it should be. It should be at the same number as the general population. So we'll talk about some of that in a while. And in Healthy People 2020, we talked about what that is. Of all those objectives, 33 are focused on maternal, infant, and child health. And some other problems that are in the healthcare system that kind of contribute to the situation. Fragmented healthcare system. So how many of you have been sent to go here to get your x-ray, here to get your lab, here to see this doctor, here to see that doctor? By the end of the day, you're exhausted and you don't know which ends up or what your diagnosis is because you've seen 30, and nobody else knows either. Everybody else does their own thing, but they can't tell you anything about the total picture of you. All they can say is, well, I can't what your labs are. That's all I know. So getting a full picture from somebody is going to be very difficult of your condition. Medical errors. Do you know that the third leading cause of death in this country is medical errors? Did you all know that? That's horrifying. The third leading, let me repeat that. The third leading cause of death in this country is medical errors. When I read that in your textbook, I was astounded. I didn't believe it could be true. That's what your textbook says. High cost of healthcare. Obviously, we know the high cost of healthcare. My son is in the Air National Guard right now. He finished his basic training. He's now in tech school in Texas. But we took him on a trip to the beach right before he left for basic training. And Holly, you can't tell this because he'll get mad. She knows I told this story. She knows my son. And my oldest son and my husband, we all went on, just the four of us, went on a trip and they went fishing, deep sea fishing. And my son got a fish hook caught in his lip right here. Went all the way through, and you have the barb on it so you can't pull it back out. So I was back at the, in the room relaxing, and I thought they dumped him and brought him up to the beach, dumped him on for me to take him to the ER. And they went back fishing. So I took him to the ER, and it just so happened, this is really not part of the story, but it is, not part of the that I probably should tell, but for some reason some woman had come into the ER and was having a baby in the middle of the ER, so we couldn't get seen because somebody was having a baby, it's like, I could deliver that baby if you're worried about it. I can do that. Fix my son. So anyway, they had to wait because they had to deliver a baby. So they come in and they tried to pull it back through and they couldn't, which I could have told them they couldn't do that. So finally they ended up having to numb his mouth, and they basically just made a little incision and then pulled the hook back through the incision and put a stitch or two in there and he was done. So I bet it took them. Once they figured out what they needed to do, it took them less than 10 minutes. So this was just in a little ER, just a little community hospital. So we get the bill. And we got a bill for a full-fledged surgery. Operating room, anesthesia, everything. Now, his anesthesia was a little bit of local, around his lip. And that bill was $6,000. $6,000 for that little itty-bitty fish hook. I was just shocked. Now, my insurance did pay a portion of it, but it still left me, I paid 20 insurance, so it still left me a couple thousand to pay, or $1,500 or something like that. So that's just an example of the high cost of health care. So even if you're insured like I am, and my son said, we took a picture of your fish hook. He said, "Can you put that on Facebook?" So you all, I think Holly probably knows, the only one that knows my son. Do not tell him that I told that story. But anyway, that's just an example of the high cost of health care. That's ridiculous. And I have insurance, and my husband and I have good jobs, but it was kind of a strain for us to think, that's $1,500 that we have to figure out how to pay. So that certainly is a barrier to care. Because if you don't have that money to pay, or heaven forbid if you don't have insurance, you're going to think twice before you go to the hospital for something that you think you might be able to handle yourself. And maybe you shouldn't. And I knew he needed medical care because I knew he needed antibiotics and things. I knew that a dirty fish hook in his mouth certainly meant he needed some antibiotics. So I knew that we had to get him some health care. But my gosh, it was crazy. And then of course limited access to care, which we've already talked about. Okay, so now some dry kind of definitions, but you've got to understand what these definitions mean. You do need to know these definitions. All right, I need to move this over here. What do you like, Grandpa? Maternal mortality. The definition of maternal mortality or mortality is the number of maternal deaths from childbirth, complications of pregnancy, childbirth or puerperium being the first 42 days after the end of a pregnancy or after termination of a pregnancy, per 1,000 live births. So let's talk about what that means. So per 1,000 live births, and we can talk about it in any setting. Well, we could say, what's the maternal mortality rate in Kanawha County in 2021, let's say, since we have that's the whole year. So we could look up the information and see how many women died from childbirth or complications of pregnancy or complications after a pregnancy per 1,000 live births in Kanawha County in 2022. Or I could say at CAMC in 2022. Or I could say in the United States. You see how we can look at whatever group we want. So it says per 1,000 live births, but you've got at the end to add what population are you referring to? Who do you want to know about? Do you want to know about the whole world? Do you want to know about the United States, your county, your hospital? So that's the definition, but you have to then caveat per 1,000 live births where? Because just to say per 1,000 live births, okay, 1,000 live births in the world, in the United States, what population are you referring to? So that always has to be added to the end when you're defining mortality or morbidity. Neonatal mortality is just the number of deaths of infants younger than 28 days of age per 1,000 live births. Again, we could say how many babies died younger than 28 days of age per 1,000 live births in the NICU in CAMC in 2021. Or we could say, again, Kanawha County, or the state of North Carolina, or however we wanted to define it. But if you see that on a test, for example, remember that it's per 1,000 live births in a specific population that's been identified clearly by whoever wants to know the information. Questions about that? Okay. Morbidity is typically a measure of maternal health. So mortality is deaths. How many deaths happen in this area at this time? Or, we could say, what's the mortality, for everybody in Kanawha County who had a heart attack last year? How many of them died? For every 1,000 heart attacks, how many of those died in Kanawha County last year? Or in CAMC last year? Or whatever number we wanted to use. Now, morbidity, on the other hand, is a complication or a measure of health. So mortality, morbidity is not just an OB term, as you probably well know. It's a medical term, and we can use it in any population that we want. So morbidity, in this case, is a measure of maternal health. And maternal health is usually measured by complications of pregnancy. So basically, what are the morbidity, how many complications of pregnancy did we have, again, in a specific area at a specific time frame. Then the birth rate, number of live births in a year per 1,000 population. And once again, we have to say, what population are we talking about? Do we want to know what's the birth rate in the world last year? How many babies were born? How many babies were born alive per 1,000 births in the world? In the United States, in Kanawha County, CAMC? What are we referring to? So we can't just, how many live births were there last year per 1,000 babies born? Where? What population? What time frame? So you have to add that to the end to get it, for it to be right. Otherwise, if I said to you, your assignment is, I want you to find out how many live births there were last year. Per 1,000 births, how many babies were born alive? And you're like, well, where? For how long period of time? So you have to add that on. A measurement of any of these has to have a time frame, start and an end, and then a specific population, a county, a hospital, a state, a country. And then we can gather the data. So birth rate basically means out of every 1,000 births, how many of those babies were actually born alive? And then how many were still born, or not born alive, meaning they did not breathe. Okay. So, per your textbook, 800 women die every day in the world related to pregnancy and childbirth. So every day in this world, about 800 women die. Something related to pregnancy and childbirth. That's pretty significant, really. And then, again, these are numbers for your textbook. The mortality in the United States in 2009, so that's our measurement there were 17.8 live births per 100,000 births. So out of every 100,000 births in the United States, no, that could be right. That would not be right. More than that would be more likely to be this back. 73, 1,000. Oh, mortality. Okay, the mortality. So this many of them were not born alive. The U.S. mortality. So 17.8 per 100,000 live births, 17.8 were not born alive. That makes sense now? The mortality rate is 17.8 per 100,000 live births. That means 17.8 out of 100,000 were not born alive in the United States in the year 2009. So that's just an example. All right. So as I said a minute ago, significant disparity exists in in race because of the deaths in the United States. 35% of those deaths related to maternal care are African American women. So if there's only 13% of African American women in the population, how are 35% of the deaths African American women? Does that make sense? Does that tell you that it's double? So twice as many African American women are dying related to childbirth than should be. It should be about 13% because that's the population in the United States of African American women. It's about 13% of all women are African American. So if the death rate for them is twice that, then we got a problem. So why are African American women not getting the care that they need? That's a whole other question. I mean, I happen to know that the population in the United States, because I looked it up, is about 13%. So that's just information I looked up. But your textbook says 35% of those are African American, so that's almost double. What's it? More than double. There are 3 major causes of maternal mortality in the world over the last 50 years. And heart disease, infection, and then cardiovascular disorders, infection, non-cardiovascular disorders. So those are the main reason that women die in the world. Unsafe abortion also is a factor, but those are your 3 major causes of maternal mortality. Now, in the world, obviously, we it may be a little bit different in the United States, but that's worldwide. U.S. maternal mortality is attributed to gestational hypertension, pulmonary embolism, hemorrhage, and then other factors are listed there as well. Maternal morbidity, remember morbidity is more of a complication or a health issue. We usually look at maternal morbidity by looking at neonatal outcomes and pregnancy complications. That's how we determine whether there's morbidity, complications, and outcomes. So what are things that we frequently see causing problems in OB in women? Usually we see preeclampsia, and fluid embolism, which actually is fairly rare. I'm surprised your textbook mentions that. Renal failure, blood pressure issues are probably the biggest issues that we see in our pregnant women. Also, we're going to talk about obesity in just a minute. That's one of the biggest factors in pregnancy and non-pregnancy that causes problems. Whether you're pregnant or not, think of all the things that obesity contributes to. It contributes to high blood pressure, right? It contributes to diabetes, right? It contributes to so many things, to blood clots in some women. So most definitely, the greatest number, one of the greatest risk factors we have is obesity. And your textbook says that in 2014, 25% of pregnant women were obese. So 1/4 of all of our pregnant women were obese in the United States. And for those women, the greatest risk factors were hypertension and diabetes. And we know, whether pregnant or not, obesity is associated with greater use of healthcare services, longer hospital stays, and more complications. So right now, one of the biggest things that we could do to improve health in our pregnant women and non-pregnant women is to help find a way to control obesity. Okay, so now we're going to talk about, we're going to switch gears a little bit and talk about childbirth practices. What's different in the United States now in childbirth than was different before? Obviously, babies come out the same way. That doesn't change. But the way in which we run around our patient and get them ready to have a baby, that does change. For example, here's a picture here. Back in the 19th century, this is a picture of childbirth, and in the 20th century, look at the progression. And I will tell you that I question that this right here is progression. This looks like surgery, operative surgery. That's not progression to me, but we'll talk about that. But here you see a lot of, this is not medical care per se. Over here, what you see is other women, probably sisters, mothers, maybe midwives, but people that have had babies themselves, helping a woman to have a baby. She looks, whether she's anesthetized somewhat or not, I don't know. It's hard to say. But obviously, you see there were no men around, and babies were, kind of more like that. No men were around, and women who'd had babies before were helpers in the delivery of those babies. In the United States, some of you all wrote some of this in, well, I think it was my clinical group that wrote some of this in some of your, you watched the video and you wrote some of this in your papers, but in 1900, the year 1900 in the United States, almost all babies were born in the hospital, almost all of them, but not by 1950. I'm sorry, I said it backwards. In 1900, 95% of babies were born at home. And then by 1950, it completely flip-flopped, and almost all of them were being born in the hospital. So what happened is after World War II, the doctors started saying, come to the hospital, it's clean, it's safe, no infection. And they were true, they were right, it's clean, it's safe. And, midwives had delivered a lot of babies in the early part of the early part of the 20th century, and they said, these midwives aren't trained, they're this, they're prostitutes, they're this, they're that, don't go to midwives. Come to a doctor where you'll have a safe, clean delivery. And so women started coming to the hospital to have babies. And what that resulted in is this right here. Yeah, it was clean. Yeah, relatively speaking, it was safe. But we took our patient to an operating room and pretended like they were having surgery. Having a baby is not surgery. And treated everything like it was sterile, which was a joke because the vagina is never sterile. Which, obviously the baby comes out. And so they knocked the patient out about 5 minutes before delivery. She went through the whole labor and kind of experienced the whole labor. So we knocked her out for the actual birth of the baby, which is what you really want to be there for, to be awake for. That's what I want to be awake for. If I'm having a baby, I want to see my baby be born. I want to make sure that's my baby they gave me. But they knocked them out right before the baby's born. Put them up in stirrups and try to make them sterile, which, again, that can't be done. And then have babies in operating rooms. So that's what we started doing in the late 50s, and it really progressed until the 70s and 80s, and there's still some little bits of that left today. We've gotten away from it, thank goodness, in a lot of ways, but there's still some pieces of it left, which we'll talk about. We'll certainly talk about it in clinical whenever you have OB clinical. Childbirth today looks more like this, which is progress. I mean, this is progress. Is having a baby an illness? If you're pregnant, are you ill? You are not sick when you are pregnant. That is a normal part of life. If we didn't have childbirth, we wouldn't all be here. We wouldn't have a population. So it's not abnormal. It's not a sickness. Can you get sick while you're pregnant? Yes. But just because you're pregnant, you are not sick. So what in the 70s and 80s, what they started saying is pregnancy is not a sickness. Why are we treating women like they're sick? Why are we knocking them out? Why are we taking them to the operating room? The vagina's not sterile. You can't make it sterile. Why are we treating it like it's a sterile procedure? It's not. So we started having what we call labor, delivery, recovery in the same room. We started making the rooms look more homey. And you can see in those cabinets, there's medical equipment there if it's needed. Not always needed, but if it's needed. And the OR's right down the hall. If you should need a C-section, it's there. It's available for emergencies. But this is more, if you were having a baby in this room, or if we went backwards to, the other room. That room right there, or that room, where would you feel more comfortable? Yeah, sure, you feel more comfortable there. Rocking chairs, couches, place for your significant other to rest, place for family members to come and see the baby crib. That is much more enticing than that operative suite. So this is childbirth today. Unfortunately, that's very misleading because we still are doing things we shouldn't be doing. We're still inducing too many people. We're still doing too many medical interventions that lead to too many C-sections. But this is still better than it was in terms of the environment. Okay, so some more comparisons in the 20th century. higher neonatal mortality. We did lose babies back then because we didn't have the fetal monitoring that we have today, but the C-section rate was very low. In 1985, the C-section rate at CAUC was below 20%. When I first started working in OB, it was in 1983 or 4. And if our C-section rate got to like 18%, that we were hearing from administration, wow, what is going on? Why are you having so many C-sections? And so we were concerned about it when our C-section rate got high. We were trying to keep it down. Often patients presented to hospital for delivery with no prenatal care. Now, unfortunately, that's starting to come back around again. The reason for that is drugs. Women are not getting prenatal care because they know that when they present and they test positive for drugs, they're going to get a CPS visit. So they're starting not to come for prenatal care again. Knowledge gained by extended family support. So in the 20th century, you found out about what to do when you're pregnant from your sister, your aunt, your mother, people who did baby support. Spontaneous labor preferred with interventions only as last resort, and that is, certainly in many ways better than intervening too much, which we tend to do now. Patient in the early 20th century labored and delivered with no support from the family. So until the 70s, if you were a woman, you had a baby alone. You went in alone, the husband's out in the waiting room, and you went in alone. There was nobody with you, you were all alone. And I think that's very sad, very sad. So in the 70s and 80s, that's when men started entering the delivery rooms and kind of not always willingly, they didn't always want to, but peer pressure got the best of them, and now, no man would dare not to go in with their wife's born because they know they can't get out of it. And to be honest, once you've experienced it, I think, how many of you guys are dads? Anybody dads? One? Are you the only dad in the whole class?
Wow, I guess so.
Surprising. Okay, only one dad, all these guys. That's unusual. So I think, would you say you would want to miss your child being born now that you've seen your child be born? You hate to miss it?
Yeah, I would want to.
Yeah, you would. I mean, I can imagine that you would not want to miss it once you've experienced that. So it was a slow transition, but we are at that point now. Women, as I said earlier, women started having babies in the hospitals in the 1950s. Before that, they were born at home. Now, 21st century, our C-section rates are through the roof. That's the biggest problem we have right now is the C-section rate is too high. In some places, it's approaching 50%. CAMC, it's in the 40s, lower to mid-40s right now, and that is double probably what it should be. It is double what it should be. It should not be that high. Now, your book says in 2006, 69% of women received prenatal care in the first trimester, which that probably is true in 2006. But now in 2022, as I just said, we're starting to see that be a problem again because women who are abusing drugs are not coming to get prenatal care. So that is becoming a big, big problem. Childbirth classes, education classes are popular, and while they've been really popular, now what people are doing instead of going to a class and sitting, they're doing YouTube videos. My oldest son has 2 children, and the oldest one's 4, and I asked if they were childbirth classes. No, we're going to watch a YouTube video. That's what people your old generation do now. Instead of going to classes, you find somewhere on the internet to watch, get the information that you want. There are many more scheduled inductions of labor right now, many more scheduled C-sections. There are more interventions, like Pitocin, internal monitoring, epidurals for pain relief. Again, father the baby, and sometimes other family and friends are present at birth. What I'm finding, it's almost like a party, and it's like you're selling. I can sell tickets. Literally, I want to come in. And so when I worked in labor and delivery, I would usually get my patient by herself and say, tell me who you want to be here, because I realize that you've got 5 people that want to be here. Do you really want all those people? And usually 9 times out of 10, they'd say no, but I don't know how to say no to them. They want to come so bad. And, they babysit my other children. I don't know how to say no. So sometimes it's not really what the patient wants; it's what everybody in the family happens to want. There has been in the last 15 years, thankfully, a resurgence in interest of midwives, home deliveries, and a birth plan. And by midwives, I mean certified nurse midwives. So a certified nurse midwife has a master's degree and is like an advanced practice nurse practitioner, only her specialty is midwifery. So he or she learns to do prenatal care, deliver babies. And we have several of them in Charleston that practice underneath a physician. Now, they have their independent practice, but they've got to have a doctor to back them up, an OB doctor, in case the patient needs a C-section. Midwives cannot do C-sections, they are not surgeons. But they can deliver babies, they can prescribe medication, they can provide prenatal care. They just cannot do a C-section. So they've got to be tied to a doctor in that sense that they've got somebody to do a C-section if that's deemed necessary. But our C-section rate is remarkably high right now. And I believe that it's tied to all the interventions that we're doing. We're doing interventions so much on so many people, inducing them just because Friday, it's Friday, let's have a baby today. Because they don't have a babysitter tomorrow, let's do it today, let's induce you today, because their husband's going out of town, because this, because that. And if we induce you and your body's not ready for labor, your body doesn't typically respond very well. Sometimes it will, but more often it won't. And if your body doesn't respond well, it's like coaxing something to happen. It's like a unripe banana, literally. You can't make a banana get ripe faster, you just have to wait. And the body's like that. If it's not ready, it's hard to make it be ready. And so a lot of times the body doesn't respond, and then the patient ends up with a C-section. When we try to force the issue, we get fetal distress and things. The baby doesn't tolerate things well, and we end up with a C-section because the patient just wasn't quite ready yet, and we were forcing the issue. Other trends in childbirth, the use of doulas. Who knows what a doula is? What's a doula?
A doula is someone who's experienced with childbirth, and they're like an advocate for the woman giving birth.
Sort of like a labor coach, and they have lay training usually. I'm sure there are certifications for doulas. They're not typically, they can be a nurse, but they're not typically a nurse. They're just a person who does labor support. So a lot of individuals have hired doulas to be with them during their labor and help coach them. So we see more of that now. We are trying to keep babies and moms together, like we're trying to use after you have the baby, we don't just whisk it out anymore. I can tell you that when I worked in labor and delivery in the 80s, you push your baby out. Here, mom, he's 7 pounds, 11 ounces, looks just like you, bye. And, you might see him again 4 hours later if you're lucky. And that was it, he's gone. So we don't do that anymore. We keep the baby with the mom. Unless the baby's not doing well or mom's not doing well, we keep the mom and baby together as much as possible. Now, the disadvantage to that is that also means, your baby's in your room all night when, you're exhausted and you're up on that last night laboring, and now tonight there's your baby. And you probably could use some sleep. So that's kind of the downside to it. We encourage family members to be in the room with the patient now for that reason. So they now have private rooms, allow 24-hour rooming in with one visitor, whoever the significant other is, so that they can help mom take care of baby. Trend of discharge to home in less than 24 hours after birth. There have been laws passed now to protect women from that. You can go home in 24 hours if you want to, but if you are insured, or even if you're not insured, you have to be allowed to stay in the hospital for 48 hours after a vaginal birth, 96 hours after a C-section. That is a federal law. Because the hospitals were trying to boot patients out to the point where it was becoming unsafe. Childbirth classes, again, and their themed classes, a lot of times are popular, Lamaze and Bradley. You don't need to know the Lamaze, Bradley, different types, but, one teaches mind-body connection, one teaches other relaxation techniques. It just, they all have their theme. Father and baby takes a much more active role in pregnant for all parts of pregnancy. Now it's to the point where men are almost expected to go to every doctor's appointment with their wife, which that's great. That's what you want to do. Seems like a lot, but every doctor's appointment, a lot of men, kind of pushed to go to every visit. The incidence of breastfeeding has increased and is now a more accepted feeding method than in the 20th century. Back, in the 20s, 30s, 1920s, 30s, 40s, women breastfed their babies because that was the only source of nutrition that they really had readily available. And then as society got more sophisticated, we got away from breastfeeding. Formula became safe, it became packaged in factories, and it was clean and safe. So everybody started formula feeding your baby. Yeah, convenient, except somebody else could feed your baby for you. Breastfeeding became really not popular in the 70s and 80s. And then in the late 80s, it started being more popular again, and now it's kind of swung back around. And, you've probably heard commercials on TV, breast is best, breast is best. I mean, obviously it is best, that's what it was made for. But we can certainly safely feed our babies with formula if necessary, and if the patient so chooses. And if a woman would like to breastfeed, we will certainly help her breastfeed, and we encourage it. But it is not, there are healthy babies, and I venture to say over half of you all were probably bottle-fed babies, and you all seem pretty smart to me. So, we all are okay. It all works out. And then in the last 10 to 15 years, the biggest change I've seen, sadly, is the number of moms that are using unprescribed and illicit drugs. It's very sad. But I told my clinical group, if you think about it, what is the population that's most likely to use drugs? Young people. And that's just a fact. For young people, young adults who think they're going to live forever are using drugs. And so who has babies? Young women. And this is in the middle of their childbearing years. So it just has to go to the stands to reason that the younger women, are using drugs and they happen to be getting pregnant. No woman gets pregnant and then says, I think I'll become a drug addict. I'm pregnant, what the heck, I'll start using drugs. It's the other way around. They're already drug addicts, or they're abusing drugs, or they're dependent on drugs. And then they happen to get pregnant because they're so caught up in it, they're not thinking about birth control. And so then they're finding themselves in a pickle. So, it is very sad. I'm torn between having sympathy for these moms and being angry at these moms. I'm torn all the time because I feel both ways. I certainly have sympathy that they didn't mean to be in this predicament, but now that they are, what are we going to do about it? So it's a sad situation. And when you're in clinical, we'll talk more about it, and you'll kind of experience it a little bit and maybe see a side of it that maybe you haven't seen before, but it's a very large problem of modern obstetrics today. Okay, the legal issues in obstetrical care. There are more lawsuits in OB than any other field. Why? Why do you think that is? Why do we have more OB lawsuits than any other medical field? Any ideas?
Two patients.
What'd you say?
I said because there's two patients.
Well, that's part of it. That is part of it. Yeah, you got two patients instead of one, so that's double the possibility. It could be mom or baby with an issue, so that's part of it. Also, I always tell students, remember when you're taking care of a pregnant woman, you have two patients along the same line. One you can see and one you cannot see. So if I told you, I said to you, you got two patients today, Callie, and one of them is going to be on 7 South, and so you go to 7 South. And now, by the way, you have another patient on 5 South, and you can't see that patient today. All you can see is their telemetry, you can see their heart rate. That's all you can see, nothing else. And you got to make all your decisions today based on that. And you might give medications and they're based on that heart rate, and that's all. So you wouldn't feel very uneasy about that. Very uneasy about that. But that's what you're doing with a pregnant woman. You're giving mom medications that are going to affect the baby, and you're making decisions about mom and baby based on that baby's heartbeat alone, especially when the mom's laboring. So that's a really scary thing, and what you have to remember when you're taking care of OB patients. So the biggest reason that we have more OB lawsuits is because while pregnancy is a normal occurrence, it is a normal thing. There are complications. Some complications can be prevented and some cannot. But people believe, I think people in society believe they deserve a healthy baby. I didn't use drugs. I deserve a healthy baby. And if they don't get a healthy baby, they feel like somebody must be to blame. It must be somebody's fault if my baby's not healthy. And that's the biggest reason. In society, we feel like we deserve that. There's good medical care out there. Nobody should have a baby with brain damage. Nobody should have a baby with birth defects. It must be somebody's fault. And so, if anybody has a non-healthy baby, usually, no matter what the reason, they sue. And here's the other piece of it. They usually get money. And the reason they get money is, number one, if you take a baby in front of a jury that is in a wheelchair or is clearly physically not normal, if it's a whole jury trial, the jury's going to look at that baby and they're going to say, oh, that poor family. How are they going to take care of that baby? What's that going to cost? And so they want to award money to that family whether the doctor did something wrong or not. They just want the family to have something to take care of that baby. They feel sympathy towards that baby. So I can tell you, if you were in a lawsuit in a trial, they're going to parade that baby in first thing if it does not look normal, because that's the way they get money. And again, the jury's not thinking about the doctor. Did the doctor do something wrong? They're thinking that poor mother, that poor dad. How are they going to take care of that child? when really the trial's supposed to be about was there malpractice. Not does this family need help taking care of the baby? Clearly they probably do. But did the doctor cause that? So that's why most doctors will not go in front of a jury because of that. So if they get sued, they'll settle out of court just to avoid that. So even if they know they're not wrong, even if they're sure they didn't do anything wrong, they know better than to go in front of, than to take the chance that they have, that baby's going to be in front of a jury and they're going to get an award that way. So they settle out of court, keep everything, keep quiet, and keep that family from, keep it from becoming public. So therefore, most of the time, when someone brings a suit, they get some sort of settlement because the doctors don't want it out in the public, and they'll settle. And they don't want that baby in front of a jury because even if the family doesn't deserve a verdict because the doctor didn't do anything wrong, that's not what happens anyway. So that really is the kind of heart and soul of why we have so many obstetrical lawsuits. So anytime the proper way that this should be decided is to look at what was the standard of care. ACOG and AWON are the American College of Obstetrics and Gynecology, and then we also have NACOG and AWON, which are the nursing side of it. So they've come up with the definition of the standard of care. Now, you do need to know what this definition is, because this applies not just for OB, but it applies across the board. No matter where you're at, this applies. The standard of care. The level of practice that a reasonably prudent nurse would provide in the same or similar circumstances. So that is very general and generic, I know. But that is the definition you are held to. If you get sued because your patient fell out of bed, because you went to lunch and left the side rails down, and the patient fell out of bed and hit their head, they're going to say, would a reasonably prudent nurse have left those side rails down? No. So therefore, you're liable. Now, if the patient falls and hits their head because they climbed out to the top of the bed and fell and hit their head, and side rails were up like they were supposed to be, then they might say, well, the nurse did everything that a reasonably prudent nurse would do. The patient, went out the top of the bed themselves and fell and hit their head, so no, the nurse is not liable. So really, it is just as simple as that this is the standard that a jury is given. What would a reasonably prudent nurse do in the same situation? Would a reasonably intelligent, prudent nurse have done that? That's called the standard of care. And that is not just for OB, it's for any, we use that in NACOG and ACOG and OB, but it's also used across the board. And because of what I just told you about OB care and OB doctors settling out of court, malpractice insurance for OB doctors is usually $100,000 per year and more, and way more in a lot of cases. So it's very hard for OB doctors sometimes to keep insurance and to, make a profit even because of their high malpractice insurance. What do you think about nurses carrying their own malpractice insurance? And I'm not asking you to raise your hand. Don't tell me if you got it or not, because I don't want to know. But do you think nurses should carry their own malpractice insurance? Yes or no? How many of you think they should? Raise your hand. This doesn't say to me that you have it or not, but do you think a nurse should carry malpractice insurance? A few of you. How many of you think they should? Even, but a lot of you didn't raise your hand. Okay, so let's talk about this. So most people probably, if you would ask them, they would say, oh yeah, nurses should carry malpractice insurance. And I'm not saying that you shouldn't, but you need to give it some thought. You are covered by the institution that you work in. For example, now as a student, you're covered by the school. So if you make a mistake at the hospital, or you do something wrong, or you give a medication that harms somebody, or anything that you should not have done, you're covered by the school's malpractice insurance. If you are employed by CANC, for example, you are covered by CANC's malpractice insurance. So if you do something wrong, if you give a medication that causes a problem, patient dies in your care, and it's negligence or something else, you're covered by CAMC. They will, whatever this settlement is, they will pay on your behalf. That is all true. Now, there's usually a cap on it. I'll also say that nurses themselves are rarely sued and rarely named. Usually the doctor is sued, and then sometimes the hospital is sued. But it's rare that they name a nurse. That is very rare. Why do you think that is? Why do they mostly sue the doctor and the hospital? Where are the deep pockets? Lawyers are dumb. They go looking for the deep pockets. Why sue a nurse who makes $60,000 a year? What are they going to get? And bad publicity, number one. That looks bad on them. Nurses, are the most trusted profession. So now you're suing the most trusted profession, and you're causing somebody to lose their house. If they're not going to get much good publicity out of that, so they go where the deep pockets are, the doctor and the hospital. So that's who they sue usually. Only in a rare situation where the nurse really, really screws up would they actually name the nurse. If you did something really bad or intentional, or that they might name you. But usually they do not name the nurse. So if you are sued and the hospital pays a settlement for you, this doesn't typically happen, but it has happened on occasion. The hospital can come back and say, I just paid $800,000 because of you. Number one, you're fired. Number two, I'm suing you for the $800,000. I want it back. Now, I'm not saying they would always do it because they know how much they pay you. They know you don't have it too, but it has happened. There are cases where nurses, the hospital has been very angry at a nurse, and maybe the nurses run their mouth at the hospital. And, in the case of revenge, they sued the nurse for some of that money, and they also could fire you. So that could happen. The other thing that happens, though, if you there's another kind of malpractice insurance, and I believe CAMC and the school has the kind that, let's say, when you're working for CAMC, you did something, and there was not a lawsuit until 6 years later, which happens sometimes. And you're already moved, you're a traveling nurse now, you're in Florida. But 6 years, you get sued for something happened 6 years ago. And usually in that case, the insurance that CAMC has, and most hospitals have this, that you're covered from the incident when it happened. Like CAMC will still cover you because you were working for them when it happened. But there are hospitals that have insurance that's not like that, meaning if you don't work for them anymore, too bad. You're on your own. So in that case, you may want to have malpractice insurance. If the lawyer would even decide to sue you, they can still sue the hospital though because you worked there then. And then the other thing, here's the negative though about having malpractice insurance, is that if you have malpractice insurance and a lawyer knows, what have you just become? A deep pocket, right? You got a $2 million policy. Okay, that's a deep pocket. And you might say, well, how would a lawyer know? You would be shocked. Charleston's a small town. I have actually had lawyers that I knew personally say stuff to me, and I could tell they were, do you know so-and-so? Hey, I heard you were a nurse. Do you know so-and-so? She works in the ER at Memorial. Do you know her? Yes, I know her. And, they start inquiring, and next thing you know, they find out that person has a malpractice insurance. And they have ways of finding out. So once they find out you have malpractice insurance, you can become a target. So I'm kind of just presenting all that for you to make your own decision. I'm not saying you should have it. I'm not saying you shouldn't have it. I'm just saying there are two sides to it. A, you're usually covered by your hospital. But B, on the other flip side of that, your hospital theoretically could sue you. And then on the other side of the fence, you can become a target if you have a big malpractice insurance policy. So if you do have one, I would be very, very quiet. I would not tell anybody I had it. I would not sit in the nurse's lounge and discuss my policy, because you'd be surprised how that gets out. And the wrong person asks the wrong question, and somebody's just looking for information, and they don't, an innocent person doesn't realize that, and the next thing you know, you're a target because you've got a big old $2 million policy. So that's just some food for thought, honestly. That's not that part right there is not testing stuff. That's just discussion about my practice. I do want you to know the definition of standard of care, most definitely. And why OB lawsuits are, why we have more lawsuits in OB than any other specialty. And it's usually because of the high incidence of settling out of court to keep from having to go to court. And in order to avoid errors, bad outcomes, and things that we don't want to happen, hospitals now are actively trying to prevent errors from happening. So there's a whole risk management department now that identifies risks and establishes preventive practices. And actually, as I said, your textbook says in 2013, medical errors, the third leading cause of death. That is just shocking. The sentinel event. Do you all know what a sentinel event is? What's the definition of a sentinel event? Well, it doesn't have to result in death, but it could. Serious physical, psychological injury or death. Or also, there are also cases where it may be psychological injury. For example, if the wrong baby got sent home with the wrong family, that's a sentinel event. Nobody died, but that is a sentinel event because it's very serious, and it causes a lot of psychological damage. So a sentinel event can be psychological, it can be physical, it can be death. Sentinel event occurrence require immediate investigation and immediate interventions. If I send the wrong patient home with the wrong baby, you can bet I'm in big trouble if I'm the nurse that discharged that patient. That's on me. And I want to knock on wood whenever I find some. That's not wood. Never happened at CAMC that we know of since I've been there in the early 80s. When we look into these occurrences, we don't really want them to be punitive, although sometimes they end up being punitive. But the hope is that we A, minimize damage, and B, figure out how to keep from happening again. So if I send the wrong patient home with the wrong baby, we got to do some investigation, and we got to go backtrack and see how did that happen? Where did the system go wrong? Where did I mess up? Or where did another nurse mess up that caused me to mess up? But how did we mess up that the wrong patient went home with the wrong baby? And we go back and rewrite our policy so that that does not ever happen again. So that's an example of a sentinel event. Infant discharged home to the wrong family. Patient receives the wrong medication. They're supposed to get an antibiotic and they get something else instead. Patient falls. Like I said a few minutes ago, patient climbs up to the top of the bed and falls out, hits their head, cracks their head open. There's also something called failure to rescue. That can cause a sentinel event. Failure to rescue basically means something bad's going on and you don't recognize it. You don't see it coming. You don't head it off. You don't realize your patient's bleeding to death after you just had a baby. Because you were in the nurse's lounge chit-chatting and you went too long without going to see your patient. By the time you saw her, she lost half her blood volume in the bed. That is failure to rescue. Not recognizing or acting on early signs of distress. So that was a good OB example, postpartum hemorrhage, uterine rupture, eclampsia, and we'll talk about preeclampsia and eclampsia a little later, but those are OB examples. Other examples, patients having a stroke or a heart attack that nobody recognizes it. And it happens without anybody, the nurse being astute enough to see something that's happening. That's failure to rescue. And then you all learned these, but as nurses, we had to relearn a lot of this because a lot of this has changed, and so we have to practice differently now. So some of us old nurses are still learning not to do this. For example, the trailing zero, we never put 15.0 milligrams because somebody might misunderstand it as 150 milligrams. We just put 15 milligrams. We use ml instead of cc. Those two terms are interchangeable. They're the same measurement. A cc is equal to an ml, but a cc could be mistaken for something else, so we use ml. The at symbol, which is very hard for me, I've used that for years, but the at symbol should not be used anymore. We write it out now. And we should have a leading, we don't want a trailing zero, but we do want a leading zero. So if we put 25 milligrams and somebody doesn't see the dot, or .C, I just did it. 0.25 milligrams is what it's supposed to be, and you don't see the dot, and you say 25 milligrams when it's supposed to be 0.25. So you put 0.25, and it's much more clear of what you mean. There's other ones. One of the most common abbreviations that can get mixed up is MgSO4, which is magnesium sulfate, and MSO4, which is, what's MSO4? Morphine. MSO4 is morphine. MgSO4 is magnesium sulfate. See how close that is? One letter difference. So it'd be very easy for a new nurse who did not really familiar with those to get those confused and not know which one of them you're talking about. And then when you communicate, of course, you all learn SBAR, right? Situation, background, assessment, recommendation. Well, under I think it's clinical content. There's an SBAR situation for OB. It's typed out there. It's an example of how you would use SBAR and call on a doctor with a problem. So I would recommend that you just read that. That's just a good example for you of what information is included. You call and you tell them the situation. Dr. So-and-so, I've got your patient here in room 310. Her name's blah, blah, blah. She was admitted today. Rule out labor. Background. She's a 25-year-old, gravid of 3, parent 2, who has no prenatal problems, group B strep negative, so on and so on. Her background assessment is I checked her when she came in. She was 2 centimeters. I sent her out to walk. I checked her 2 hours later. She was 4 centimeters. She's contracted every 3 minutes. I think she's in labor. I would like to admit her recommendation in labor. So you can read that whole thing. You use that, and it's clear and concise, and everybody understands what you're talking about. You can also use that when you give a report at the end of your shift. And until you get used to giving a report, I would recommend that you do that because it's a way to organize your thoughts. Worst thing you can do when you give a report is to jump around back and forth. First, you're talking about the situation, then you're talking about what you want to do, and then you're talking about the background. And it's very hard for you to be followed. So organize your thoughts so that you are organizing each section, and then whoever's listening can follow what you're saying. Okay. I went and corrected most of them, but I guess I missed that one. Table 1-1.
The left column, table 1-3.
Okay, now I've talked about already providing obstetrical care. The most important thing to remember is when you have a pregnant woman, you have 2 patients and not just 1. Now you're going to learn that up until probably the middle of the 2nd trimester, there's not a lot we can do for that little patient. They're not viable yet. So most of our decisions then are just based on mom. But when we get to the 3rd trimester and the baby can survive outside the mom, then all those decisions become much more magnified. Because sometimes it's better to get the baby out on the outside and take care of it that way if things are on the inside aren't going well. And that's a determination that has to be made. But at the end of the day, we always think about mom first. Without mom, you have no baby. So even though you have 2 patients, they are both equally important, but at the end of the day, mom has to survive first. The only exception to that, which we'll talk about, is if you have a mom who's been shot or stabbed or something and they're clinically dead. I mean, that's a whole other rabbit trail that I'm not going to go down right now, but 99.99 times out of 100, mom is what we're worried about. Okay, so we've got, take just a 3-4 minute break. We've got about 25 minutes, and we're going to start in chapter 3. Okay.
Also, I don't know if she said anything, but anyone who is going to help with the teddy bear fair afterwards, we're going to have a short little meeting if you guys don't care to stay.
Yes, thank you.
I just saw them before.
Yeah, I forgot to mention.
When I put that on down, I forgot to get t-shirts. So I
requested it, but she hasn't accepted it yet. I was supposed to wait till her. I think it's not. Or should I call?
I'm not best at decisions like that. So.
What was it again?
I requested days of work, but she hasn't approved it yet. I said, should I just like take the day off?
Do you work from? That's the biggest one. If you want to work, call. If you don't call.
Well, I don't ever want to work. And that's when we started back to school. Yeah. My paychecks fluctuate so much.
Mine too, because I found another box for
the other one was
I can't do that.
TK, which I so I was like, should I do it over?
I need to ask people in my group what somebody has been saying.
Oh, yeah. Oh, it's
What? I was like, I'm scared of travel.
She's scared.
Yeah,
Well, it could be.
And she does, like she has flowers, she got it's zombie apocalypse, she has, if the zombie apocalypse ever hits, she's gonna. Oh, yeah, I got one because, well, we do too, I went crazy over it. We have, when my house was, I had to have a room built on, put on my access things. I mean, I had oodles and But there's a lot of stuff. There's all the desert things. Oh, yeah. Whatever. People call and say somebody's been in your house. Down summer. Are you gonna try to rebuild or? No. I think when I get out of school, I'm making some changes to my house.
That's not even studying.
I'm putting windows in it. Because the windows is in it. And I thought the two windows, so you can't really open it. Yeah. So I'm gonna have new windows in it.
As soon as I
And I'm putting the trim up, and I'm changing the light fixture.
Yeah.
I think a lot of people, and I'll do some things like that, and fix the front porch. I'm gonna fix my front porch, it's gonna go fly over.
Yes.
Yeah.
Like you look at the back, front of my house looks like a cottage, a one-story cottage, but the back is 3 levels because I have the basement upstairs and the main floor. And my deck, you only get to it out the kitchen, out the main floor.
Yeah.
So it's very static.
I think my taxes to come in. I need to see if there's
Yeah, that's what I want to do.
if my I know it's not here yet, but I will look and see where it's at. It said most early e-commerce, most refunds arriving by March 1st. But mine doesn't have a status on it yet. So I don't know. And it's not like I have a bunch of stuff taken out and getting on. But we can't really until we have taxes. So,
Oh, there's the.
dang, I'm so cold. I'm like freezing. I feel like I'm gonna like so cold. I've been cold for a while. Did you miss the question about the diabetic neuropathy?
I didn't really look at my rationale, so I just figured I'm going to go over it with her anyway. I didn't like it because I'm an idiot.
Well, she was looking on my shoulder because I accidentally raised my hand before I'd even looked, and she saw she had to see right off from the 78. She let us out early, and she was like, I better not see anybody get us in the 70s. And I'm 78, Calico 78.
Way back.
It'd be alright. It'd be alright. I still have to be in here. Still not up there. I'm gonna punch the IRS.
Okay, I think everybody's fine, we're making their way back, so I want to try to get us far into chapter 3 as I can. So, in your chapter 1, 3, 5, and